Good morning. This is Dr. Bill Wyatt, and I am a general dentist, but I've done nothing but orthodontics for the past 45 years. I did a lot of TMJ stuff. I mixed in with the orthodontics also, but nothing but orthodontics. I want to pass on a lot of the things that I've learned during this time. And I would like to tell you, if you're a general dentist or pedodontist or any kind of dentist, you can join the American Orthodontic Society. And we have a lot of good teachers that will show you how to do orthodontics. And if you get in the American Orthodontic Society, you can pass the boards. We have board examination. And we have an annual meeting, a real nice journal, and it's a good place to be. You really need to be in an organization if you're doing orthodontics. One thing I wanted to cover this time is malocclusion. So much of it, and we feel like it's caused by mouth breathing is one of the real big causes for malocclusion. You think, well, how does that happen? And I want to show you some of the ways that this does happen now. And now we're going to go ahead. One of the reasons I want to cover today is that we have large adenoids in some patients and big tonsils, and it kind of blocks the airway, and so you can't get air through the nasal cavity, even have a problem sometimes through the regular channels there with the large tonsils. But you need to get a child going with this teaching them how to swallow properly and everything. I'll try to cover some of the causes for that. This case will show reasons for two-phase treatment, which must be begun early. You have to go in and get a child corrected, get this functional problem corrected while they're young, and I'll try to bring that up too. Now, this young lady has a breathing problem. She's got a little too much vertical height of the face. It really, you need about the same amount of distance between the nose, the eyebrows, and down here it's more. So this causes the jaw to open further, and so as it opens, it swings like such. And so if you get it closing right, this part will come to, and she'll have a little better profile up here than she has now. These lines are just drawn. They're not anything accurate about it. But anyway, she's got a breathing problem, and she breathes through the mouth. And when you breathe through the mouth, you don't swallow properly. An adult swallow pattern, you bite your teeth together every time you swallow, and they tell me you swallow somewhere around 2,000 times, and that's a lot for every 24-hour period. Now, if you bit together with a pound of force every time you swallow, that's 2,000 pounds of that these teeth have been exposed to during a 24-hour period. And they stop erupting when the amount of force comes up against them, and that makes the height of the face where it is. Now, if you take this force away from the teeth, they will continue to move toward one another more than you want them to. And this is why we develop these long lower thirds of the face. And this really fouls up here the beauty of the face. Now here, this is not so much, it doesn't detract from her looks, but it really kind of makes her chin go back. If you close the chin up, it moves forward as it closes. It swings off of the condyles up here. All right, let's take another look at her. This from the front, it looks pretty normal, and it hasn't got so much, but the facial length down here is more than the facial length up here or up above the body. You try to divide the face in 3 equal parts. If you come down, this will be somewhere along in here. So you want to stop this in this facial growth down here. The lower third of the face gets long and the chin swings back. So that's just a fact. It's just the way it develops. All right, we look at this young lady again here. We didn't take these pictures until we had started the orthodontics, and I'm sorry for that. So you don't see her right off, but I'll show you the models in a little bit. But she's got a little gumminess of the smile, and that brings about a lot of times when we let the face get longer than it should, it tends to get more this gumminess of the smile. And if they have the chin down further, your lip tends to stop in here. If you're breathing through the mouth, you don't pull the lip down or keep it pulled together, and people have little short lips up here from just not swallowing properly and holding their mouth open to breathe. Now, here on the models, you see this is no big problem, and this tooth is coming in wrong and it's being hit right here. She's keeping her mouth open, and so you develop these deep bites a lot of times from doing this. Now, the bottom teeth hitting the back of the upper teeth kind of locks the jaw back. The jaw doesn't come forward. Now, watch what happens in this jaw when we level these teeth, pick these up, and have a proper overjet, like your upper teeth meeting your lower teeth. Your lower teeth should come up underneath here a little, something like that, but not this big difference where they're biting up into the roof of the mouth up here, and that keeps the jaw from developing out here. And when we level that up, watch what happens to the jaw. The jaw will come forward, and that happens in many, many cases. Now, if you look at this from the side, you see these teeth are hitting up in here too high, and the jaw can't move out like this. So the 6-year molars are right even back here. Now, to have this correct properly, you should have this, like you have the molar in here. The lower molar should be out here somewhere, and this point come down, and this part is the back of it. And so this is partly a Class 2 case. So it is a Class 2 case doing that. Now, what can we do about this? Now we're going to lower this down, and we have to get in there early and correct that. Now, here's the other side of the mouth is the same way. This comes down right even with that. And this is a mild Class 2. So let's see what happens when we go in there and correct that. And we need to get this corrected early. Don't wait till the child is, say, 12 or 14 years old, or some of them are older than that. And years ago, the orthodontist just worked on kids up in here, and most of them did. There was very little interceptive and preventive stuff done. So you've got to start on a kid when they're very young and correct the function. And then that helps the facial structure grow right. And that's one of the big problems with this. Let's see now if we look at it from look straight up at the lower arch. The lower teeth are up in here somewhere, and they're preventing the bottom jaw from, the bottom part of the jaw from coming forward of the mandible. Now, if you're swallowing improperly, your tongue has to stay in the bottom arch all the time, and it'll make your lower arch develop wider than it should be. Now here it's not enough. She still meets right, but the tongue isn't up here as much as it should be, and so this hasn't assumed a nice round shape of the tongue across the palate right here. And the lower arch here is not way out past it, but in many mouth breathing cases, which we've shown one, these lower teeth will be way on out here, and then the upper and lower teeth meet wrong. The upper molars should come over the lower teeth, something like this, with the cusp of the lower teeth coming in here. And when the teeth meet right here, you don't bite your cheek together. Now, I'm a mouth breather and have been that way for years. My teeth are not real far out. My lower teeth aren't real far, but they meet just kind of right like this. Let me illustrate that a little better. Here's the upper teeth coming down, and my lower teeth are meeting like this, on this, and my lower's even out further, and your cheek gets in between here, and I bite my cheeks just all the time. I have to really be careful about chewing back in here. So that happens to the person. Now, if this gets worse, then your lower teeth are like here, and you go into cross bites, and you can have these cross bites on both sides of the mouth, and it can get a lot worse than this even. I've seen it in some cases. I've got a case that we've shown where the teeth actually, the lower teeth are out here, and the upper teeth are in here, and it's a scissor bite. They miss. Their teeth actually miss when they come together in here. Okay, let's get on to a little bit more of this. We wanted to talk about the adenoid tissue and the tonsils. You can't see the doggone tonsils in a self very good. Some people can pick them out, making it darker or lighter. You may be able to recognize the tonsils. I don't think we got a big tonsil problem in this case, but the adenoids was closing down. I've seen these adenoids so big that they actually touch down here. You had also no airway. So we have to send the child to an ENT person and get this problem corrected, where they may have to take the adenoids out. The tonsils, sometimes it's hard to get the ENT people to take the tonsils. Sometimes now they have to just, you'll see them swollen up to where the tonsils on one side. If they touch like this, it's a number 4, and you want them to be separated quite a bit in here, so to get plenty of airway, plenty of open space in there. If you get these big tonsils, that forces the tongue forward, and I've seen kids is actually pushing their teeth forward because their tongue was being shoved forward from these large tonsils. So you need to get that straightened out and get you a good ENT person that'll take care of that. And we did that. We got these adenoids out and got this young lady where she could breathe better and stop the tongue thrust problem. Now, looking at the first Panorex, this was 11 in 1985 when we did this case. This deciduous lateral right here is not being resorbed properly. Actually, the follicle on the cuspid should eat the roots of the baby tooth away, and where the tooth will just come on in normal. Now you got to take this tooth out right here. That's an obvious thing, and get this, because this is behind the other one. It's coming in pretty good. These are the old Panorex, and I really love that thing because you can see exactly where these teeth come together, and that's important to me. This is not a little more class 1 on that side than the other side. Now here we went in and we put a what they call a 2x4. You got 4 anterior teeth, except this one is not down far enough to get, but we'll catch it and bring it on in. Now, in addition to having the 6-year molar banded, I put a bracket on the deciduous second molar in both cases right here, and that gives you less wire in here. You can do a little bit more with the anterior teeth that way. And then I put one on the bottom too, and we banded these teeth, and we put these little wires on here that come up and point back, and we make those out of 03 old wire, and that's stout enough to where you've got the lower anterior teeth, maybe something like this, and we put this band on there, and we come in and solder these wires and build it up just so the wire doesn't hit the palate up here, and you point that back and the tongue will hit that every time they tend to go over there, and this, you think they'd butcher their tongue. But I put these on a medical doctor one time, and he had a bad tongue thrust. Even when he was about 30 years old, and it stopped him from actually pushing his tongue. And I said, I want you to tell me how you react to this. He said, well, my tongue went up there about twice, and it hit those, and the tongue remembers, and it stops going up there. So you can do this, but then you need to correct the airway, because that's one of the reasons the tongue is coming out there to start. Now, anyway, we did this, and we leveled this out and got the teeth lined up, and watched the jaw will move forward. We did very little class 2. I mean, we didn't have the class 2 elastics on it, you know, like you normally do. I don't remember putting any force to correct the class 2. All right, now this is early on. All of these are covered. These are, we got 9. Let's see, there's 3 and 6 baby teeth up above, so we got 12 baby teeth still in there, or deciduous teeth, that are going to have to come out, and you need to get this corrected way before they come out normally, and don't wait until these all get in to start your orthodontics here. Okay, now look at this a little further down the line, and we keep that in, and we stop the tongue thrust, and the bite tends to close down, and we get that corrected, and that needs to be done really early. Now here we are, we've gone through all this, and this is the 4th Panorex that we took, and I take a lot of Panorexes. We've got this molar's not out, this one is, and if you get down here where you're able to put brackets on it, you've got to wait for some of this. The upper is going along behind that. When you get this down where you've got a few of these in, you can start the 2nd phase. Actually, when you've got some of these deciduous teeth, you can take those out and you control the space like that. And you can start them earlier. But you need to get started in the 2nd phase. In these 2-phase cases, now you start to do a certain thing over here, and you go in and tell them what you're going to have to do. Now this period in here varies. Sometimes it'll be a year, or 2 or 3 years, then you come back and finish the thing up. But don't wait out here to come in and do the whole thing. Do these interceptive and preventive things first, because that whole facial structure will go wrong if you've got a real problem with mouth breathing. Okay. Now here we'll show this no big deal in here. We just going to line these teeth up. We're going to line this up, and then I'm going to open this up where these teeth have a right overjet and overbite. Free the jaw up, and it will let it come forward. Alright, there's this point. And this is a little wildcat wire that we used then, and this is probably a 036 or 018 round wire up there. And we move that out. And looking at it from upper, looking straight in the upper, we've got this going pretty good. We just move this together, and things look pretty good at this point. And now here are these little metal fingers that we use, and you have to band the teeth to put these on. Bend them down where they don't hit the palate, but it catches the tongue, and it'll hit this, and you'll go up and bump into these about 2 or 3 times, and your tongue is pretty smart. Boy, these things rake the tongue under the bottom, where it's really sensitive if it goes over them. Now they will stop that if they can breathe through their nose. It makes a lot of difference. So you work on the breathing and then work on this too. But get them breathing good before you do this down on the bottom. Now, well, I did use some class 2 correction too on this young lady. And if you start class 2, it is higher. You come off the lower molar and you come up this way, and you start pulling these teeth back. The molars will come together and don't bother them much, but you'll tend to pull the anterior teeth down. So I put an occipital headgear on her, and it has a spur in here, and it's cut short, and this comes right across where the teeth are, and it won't let these teeth drop down. So you don't want this vertical height to get any molar back here, and that is how we level this bite. This picks this up, and then we put a stiffer wire on the bottom, and it kind of folded down this way. Now we use these intruding wires, which are really excellent. Now here's the headgear. It pulls up, and the deal is cut short in here. If you want to pick the like the maxillas in here, you'll pick the front of it up this way, and the class 2 elastics is pulling it down, so you don't let it do anything up here at the front. It stays steady. Now when we open that bite, the lower jaw just comes forward quite good. Now we did use some class 2 correction to do it. Now let me show, that's a bad picture right there, but there's a spur on this headgear, and you put it right between the wires, the arch wire right here to pick it up, and you have this out in front. This inner part of the headgear does not touch the teeth, and then you got your deal out here where you hook it and have it close to the straight across from where the front teeth are. Now here's this little spur that sticks out, that's bent where it doesn't hit the teeth, but it catches this arch wire and picks this up. Now this is a good way to do that, where you don't open the bite at all doing this. Now you can, today they've got a deal that attaches back to the molar, and they set it on the cuspid up here, and you pull back from that, and you make the molar pay for backing this up, and they don't use the headgear, which is a good thing, and it's somebody really thought this out good. Your bar back that you run across here will tip down as you pull it, but then you tip the molar, and you're pulling on the bottom arch down here, makes the bottom molar move up back in the back. The upper molar, which should be somewhere like this. Now they're together, of course, and you've got something rigid off of this one coming up here, and you put the elastic off of that. You got it on the cuspid too, just kind of swinging here, and you pull back on this, it tends to tip this upper tooth backwards. It pushes back on it, so it rotates somewhere like that. The lower molar is being pulled this way, so it tends to tip in the other direction, and that puts these molars, if they chew properly, they just don't move much. They'll open some, and so you can correct this without lowering the front teeth. Now this is a new gadget they have out now, and that's a good thing. You could do that with a Big Daddy arch wire too. So anyway, we use the occipital headgear to raise this up, or to keep it from coming down from the class 2 pulling on it. And that needs to be done early too. Now here we got the young lady like this. Now this is down, this is up. Excuse me. Now this has got the overjet and overbite about corrected, and this is the first phase. We've still got a bunch of deciduous teeth in here, and we're going to do the second phase when they get most all of these teeth in, except maybe the second molars. You can, and you've got one or two of them still there, you can extract them, and then you put everything on here, and it controls the space in here. But these things are corrected early. That's what I want to get across to you. If you went a long time before, I mean, from, say, we get through with them when they're about 8 something in here. If you wait another 4 years, I'm going to show you some things that go wrong that are bad for the child's development. In other words, the face will get longer. These teeth will erupt together in here, and the facial structure gets out of shape, out of proportion. And some of them get a lot worse and look a lot terrible. I mean, they just have to have surgery to correct them like that. Now we put a retainer in, and I never cross over the teeth with anything holding. These are wraparound retainers, and they can be made to fit in the mouth so tight you can't hardly take them out if you want to. You put a little composite under the wire back here, good composite. You have to snap them up over it if they're coming out. But most of the time they just stay, nearly all the time, they'll stay up in there just from the vacuum from the inside of the mouth. And the teeth are allowed to grow together, and they function against one another, and they kind of grind in like valves or something in the car. They wire into place. And if you use any type of retention, like these little plastic shells for retainers, are not good. They're the same thickness all around here. While you're wearing them, you're closing the molars down in these teeth or parts. You take them out and they don't meet good, and people stop wearing them kind of thing. So I don't like that. I want a good wraparound retainer in here, and you wear that until these baby teeth are all out. Now the permanent teeth are in the bottom, and you see this has come to pretty much class 1 relation in here. And if you remember right, these teeth were behind something like that, and the molars were off too. So this is corrected. You won't have a great deal to do in the final phase of the treatment. And this is meeting good. You see we got a good class 1 relation back here in the molars. And this is out. This is moved good. So now we've already quit on this case. Now the lower teeth are lined up good, and we're just waiting now for to get rid of this. And over here we've got them all out. So you've got you can start the case. Now up above they're still in, a lot of them, so you're gonna have to wait longer to get in here till you got most of the teeth in there. Now from the upper, you see, the lower ones came out a lot faster. We still got 3 deciduous teeth in the mouth there. They're way behind on the upper. All right, this was the last part that I've got on this video itself. The reason for a lot of malocclusion is mouth breathing. I'm going to go back and show you. You need to get the person breathing through the nose. If we breathe through the mouth, your nose filters the air, it humidifies the air, and it works kind of like the carburetor. It makes the air go faster, so it goes out into the lungs better. And you filtered it and you warm it to body temperature. Now I've been showing that for years, that these are the things, and I was unaware of the other benefit that nose breathing does. Now the sinuses actually form nitrogen oxide, or just that's wrong. This NO, nitrogen oxide. That's one of each in here. That's not N2. It's nitrous oxide. It's laughing gas, and it helps you if you don't. You can do that in your case, or used to, but you have to watch. If you get too much of that or sit there, it robs your oxygen and can cause you to die, actually. So we use, but this is a unknown gas, and it benefits you so much. If you question that, look it up on YouTube or go on Google and see the benefits of breathing through the nose. The sinuses produce nitrogen oxide, and nitrogen oxide has all sorts of benefits. It comes out of the sinus and gets in the air that goes down into our lungs. It relaxes the muscles in the veins and things where you get more flow, more blood flowing here. If you're breathing through the nose and you get this nitrogen oxide, you will get 10 to 15% more oxygen in your blood system, and this is a real benefit. You see some child that's sitting over there breathing through his mouth and got his mouth wide open and he just looks kind of dull. He's not getting the amount of oxygen that he should get. Everything gets better if you get more oxygen, it seems like, you know. I've got some stories I can tell on that, where worked on somebody where we had to take the whole maxilla out. You see, I've scrubbed in on some of these cases, and the maxilla's lying out here in front of the tongue, and they trim it off, shorten it. On the case I worked in on, they cut about 10 millimeters off the top of the maxilla through the sinuses and everything, and then we wired that back up, and thank God that he's there to heat it up, because that is you wonder how on earth it comes out. Now that's maxillary surgery, and this is a terrible price to pay for not going in there early and correcting these things and keeping the facial structure from growing too long. Now this nitrogen oxide also is bactericidal. It kills a lot of the bacteria. It also kills virus. It helps in preventing allergies, and it does all this good stuff in the airway, and you get more oxygen. And if you, there's some funny thing here, they say if you hum or vibrate the tissue up here where the sinuses are, you'll get 10 or 15% more of this nitrogen oxide into your airway. I don't know whether this is a reason where people hum or just normally you get a lot of that. It gets down in the lungs and it softens the arteries and the veins there, and they can handle more blood, and it carries this nitrogen oxide to the heart and is beneficial to it. Now if we leave these kids till they get 12 or 14 years old, they've gone through 3, 4, 5 years that they don't get this good stuff. It not only makes the facial structure go higher, but it keeps their brain from working properly. This can't say enough for interceptive preventive orthodontics. Gosh, this ought to be done on every child if it can possibly be done. And I think that pedodontists, the people that are working on these kids real early, should start this and do this. And when they get older, if you want to send them off to do that, or if the second phase is not anything, they should just go ahead and finish. Now, we would send the real bad stuff to the orthodontists. They should be able to handle all that. Now, we're doing adult orthodontics now. They used to not. But I've done cases in adult orthodontics when they were in their 80s, sometime up in the 88 like this. I've never started one that was 90 years old, and I don't guess I've retired here myself, but I didn't retire till I was 88 years old. And I started doing these videos during my retired time, and I want to pass along this on to you. Now, this is a big reason for getting it early on these cases and prevent this from happening. Then that prevents a lot of this orthodontic surgery. If you're a dentist and you can get with a surgeon that will let you just watch one of these, you'll wonder how in the heck the people heal up like they do. And sometimes they don't heal good, so they put them in an oxygen tank. There they breathe this almost pure oxygen, and it'll get the blood back in here where it carries enough oxygen to keep the tissue growing. So don't cause this child to have to go through this hell, you know. Go in there early and correct it, and they don't need that problem. So I'm going to push and close this out, and I hope you will get some benefit from this video. Let me get over here and we'll close it out.